So drugs that act on the kidney have important applications in renal, cardiovascular, and endocrine disorders. These disorders mainly involve sodium and water homeostasis. Each segment of the nephron has a different mechanism for reabsorption of sodium and other ions. The subgroups of the sodium-excreting diuretics are based on their sites and processes in the nephron. Several other drugs mainly alter water excretion. The effects of the diuretic agents are predictable from knowledge of the function of the segment of the nephron in which they act. So, for drugs used in renal disorders, we have drugs that modify the salt excretion, and we have drugs that modify the water excretion. For the drugs that modify the salt excretion, just remember the parts of a nephron, which are the PCT or the proximal convoluted tubule, DCT, and the distal convoluted tubule, or the TAL, which is a thick ascending limb of loop of Henle, and then we have the cortical collecting tubules or the cortical ducts. And then we also have osmotic diuretics in each group, because osmotic diuretics not only modify the salt excretion, but they also modify the water excretion. So now let's talk about the drugs that act on the PCT or the proximal convoluted tubule. For that, just remember carbonic anhydrase inhibitors, including acetazolamide. First of all, I want you to remember what loop diuretics act on. Of course, they act on nothing but the ascending limb of loop of Henle. And then let's also talk about what thiazides act on. They act on the DCT or the distal convoluted tubule, and then the cortical collecting tubules. They are going to be acted upon by the potassium sparing diuretics, including the spironolactone. And then we have osmotic diuretics, including mannitol. Okay, so drugs that modify water excretion are going to be ADH agonist, including desmopressin, or ADH antagonist, including a drug called conivaptan. This is a captan. Okay, I'm just kidding. Renal transport mechanisms and diuretic drug groups. Kidney filters plasma water and solutes at the glomerulus at a very high rate, which is going to be GFRA is actually 180 liters per day, and must recover a significant percentage of most of these substances before excretion in the urine. The major transport mechanisms for the recovery of ions and water in the various segments of the nephron are shown in the figure, which we're going to discuss later. Because the mechanisms for reabsorption of salt and water differ in each of the four major tubular segments, the diuretics acting in these segments have different mechanisms of action. Most of the diuretics act from the luminal side of the membrane, which is the internal side. An exception is the aldosterone receptor antagonist, which was spironolactone and eplerenone. Okay, so here we were talking about the potassium-sparing diuretics, which act on where? They act on the cortical collecting tubules, and they do not act on the lumen. Okay, so these are spironolactone and eplerenone only. These drugs enter the collecting tubule cell from the basolateral site and bind to the cytoplasmic aldosterone receptor. To remember this easily, you can also remember that the aldosterone antagonist groups, they are going to enter from the basolateral side and not the luminal side, and they are going to sit in a CAR. So CAR is basically cytoplasmic aldosterone receptor. This is very difficult to remember. The kidney contains numerous adenosine receptors and prostaglandin receptors. Agonists and antagonists at these receptors can alter kidney function directly and also alter the response of the diuretic agents. So prostaglandins are important in maintaining the glomerular filtration. When the synthesis of prostaglandins is inhibited, for example by the NSAIDs, the efficacy of most of the diuretics will decrease. Okay, so this is something very important. During pregnancy, the fetal kidney is chiefly responsible for amniotic fluid production after the 20th week. NSAIDs should not be taken in pregnancy after this time, whether or not they are receiving a diuretic. Here, what do we have here? So acetazolamide is acting where? It is a carbonic anhydrase inhibitor, so it is supposed to act on the PCT, which is the proximal convoluted tubule. Here, it is acting. Then we have the mannitol, which is an osmotic agent. So where is it acting? It is acting here, which is a collecting duct. Then we have loop agents. Example, furosemide. They are supposed to work in the ascending limb, thick ascending limb of the loop of Henle. So this is where it was. And then we have thiazides, which are going to act on the DCT. So this is where they are acting. And then we have aldosterone antagonists, which are going to act where? They are not luminal, and they are going to act on the cortical collecting tubules. Can you see them? Where is 5? Here. So NaCl plus aldosterone. And then we have ADH antagonists, which included conivaptan. Here they are acting. Then we had adenosine. Adenosine is acting where? It is acting here. Okay, so tubule transport system in the kidney and sites of action of the diuretics. So circles with arrows denote known ion co-transporters that are targets of the diuretics indicated by numerals. Question mark denotes preliminary or incompletely documented suggestions for their location. ADH, PTH, blah blah blah. And then we have these important terms to learn. So what is a bicarbonate diuretic? It is a diuretic that selectively increases sodium bicarbonate excretion. Acetazolamide is doing that, so it is a bicarbonate diuretic. Example is carbonic anhydrase inhibitor. So diluting segment is a segment of the nephron that reabsorbs solute without water. So for example, I am namak and I am reabsorbing salt. For example, I am something which is a leech. For example, I am a leech and I am feeding on namak or salt without actually taking in water. So I am a diluting segment. The thick ascending limb and the distal convoluted tubules are active salt reabsorbing segments that are not permeable by water. So DCD, where the thiazides act, and the thick ascending limb of loop of Henle, where the loop diuretics act. They are the sites which are diluting segments where water is not permeable. Now let's talk about hyperchloremic metabolic acidosis. So here chlorine ज़्यादा हो गया and metabolic acidosis हो रही है. A shift in the body electrolytes and pH balance involving elevated sodium chloride, diminished bicarbonate concentration, and a decrease in the pH in the blood. Typical result of bicarbonate diuresis. Bicarbonate diuresis का result है यानी carbonic anhydrase का result है hyperchloremic metabolic acidosis हो गई है. Now let's talk about hypokalemic metabolic alkalosis. ये तब होता है जब हाइपोकलीमिया हो जाता है जो कि काफ़ी ज़्यादा ड्रग्स का साइड इफेक्ट है डायरेटिक्स का. A shift in the body electrolyte balance and pH involving a decrease in potassium secretion, serum potassium, and an increase in the blood pH resulting in as a result of loop and thiazide diuretic actions. ठीक है. Then nephrogenic diabetes insipidus. Loss of urine concentrating ability in the kidney caused by lack of responsiveness to ADH. ADH is normal or high लेकिन respond नहीं हो रहा है. Lack of urine concentrating ability in the kidney. Then we have pituitary diabetes insipidus. It is a loss of urine concentrating ability. दोनों में loss of urine concentrating ability भी है in the kidney, but pituitary diabetes insipidus is due to the lack of ADH, which is ADH is going to be low or absent. ठीक है. And then we have potassium sparing diuretics, which will reduce the exchange of sodium for which will reduce the exchange of potassium for sodium in the collecting tubule, which is a drug that increases sodium and reduces potassium excretion. Example is aldosterone antagonist. Okay. Then we have uricosuric diuretic, which is a diuretic that increases the excretion of uric acid, usually by inhibition of uric acid reabsorption in the PCT or the proximal tubule. Example is ethocrinic acid. Here we can see the mechanism of sodium bicarbonate and glucose reabsorption into the proximal tubular cell. So this is the lumen, this is the proximal convoluted tubule, and this is the interstitium or the blood. So first of all, we're going to see how carbonic acid is going to be formed and what carbonic anhydrase does. So firstly, in the first step, H2CO3 or carbonic acid is formed from HCO3 minus plus H plus or bicarbonate ions plus hydrogen ions. So the first step is going to be bicarbonate reabsorption. So bicarbonate is just going to be formed here in the lumen. Okay, so now let's talk about the second step. This happened in the lumen as well. So in the second step, carbonic anhydrase is going to break down carbonic acid into water and carbon dioxide, which we can see here. Now the third step is going to happen inside the proximal convoluted tubule. So what is going to happen is that carbonic acid is going to break down into hydrogen and HCO3 minus. So H2CO3 is going to be broken down into H plus and HCO3 minus. Okay, so this was the third step. In the fourth step, bicarbonate is reabsorbed into blood across the basolateral membrane together with sodium through the sodium bicarbonate cotransporter. So in the fourth step, we can see here that bicarbonate is going to go out. So this is the fourth step, this is the fifth step. It is going to go out along with sodium through sodium bicarbonate cotransporter out of the cell into the interstitium across the basolateral membrane, which is shown here in the dark pink. And then what is the fifth step going to be? Hydrogen generated inside the cell is resecreted into the lumen by sodium hydrogen exchanger NHE3, which restarts the cycle. So here we can see NHE3. Sodium is going to go inside the cell and hydrogen ions are going to be secreted out. This is going to happen through the sodium hydrogen exchanger pump. And so the result is that filtered bicarbonate is reabsorbed indirectly and hydrogen ions are recycled and they are not lost. Okay, now let's talk about what happened here. So here we can see sodium and we can see glucose as well. Why are they together? Oh my god. This is happening through the SGLT2. Here we can see. So glucose is reabsorbed, but how? In the lumen. So this was the lumen in the center. So sodium glucose co-transport. Glucose is going to piggyback sodium against its concentration gradient. Inside the tubular cell, glucose will exit across the basolateral membrane into the blood through the facilitated transport, which is gut transported. And nearly all of the glucose is reabsorbed in the proximal convoluted tubule in normal conditions. Okay, now let's talk about the last thing, which was sodium potassium ATPase pump. Okay, so this is going to make 3 sodiums go out and 2 potassium ions go inside. So intracellular sodium concentration is going to be low, which is going to drive sodium entry through the sodium hydrogen exchange pump or NH3 pump and sodium entry through the sodium glucose co-transporter or SGLT2. Now let's talk about this table. So we have carbonic anhydrase inhibitors. And first of all, let's talk about the NaCl excretion in urine caused by these drugs, these 4 classes of drugs. So carbonic anhydrase inhibitors are only going to cause a weak excretion of sodium chloride because they block sodium bicarbonate excretion, which leads to increased loss of bicarbonate. And this is going to be self-limited for 2 to 3 days. And what about loop diuretics? Loop diuretics will block the sodium potassium 2 chloride co-transporters, and they're going to be very potent excretors of sodium chloride. What about thiazides? They're going to inhibit sodium chloride co-transporter, so they are going to be moderately potent. And what about potassium sparing diuretics? They are going to be weakly excreting sodium chloride by blocking because they act late where little sodium remains. Now let's talk about sodium bicarbonate excretion, which is mostly done by carbonic anhydrase inhibitors. So because they are going to markedly directly inhibit carbonic anhydrase, carbonic anhydrase will directly inhibit bicarbonate. This will decrease bicarbonate reabsorption and bicarbonate naphthuria. This is going to, okay, now for the loop diuretics, not significant change in thiazides, no significant change in potassium sparing drugs, no significant change in sodium bicarbonate excretion in the urine. This is mostly done by CA inhibitors. So potassium, of course, when we talk about potassium, first of all, I'm just going to say that potassium sparing drugs are going to cause decrease in the sodium excretion because they're going to block the sodium entry, which is going to result in less potassium exchange, or they're going to antagonize aldosterone, which leads to hyperkalemia. And loop diuretics have very high sodium load to the distal convoluted tubule, which stimulates potassium secretion. Major hypokalemia risk is going to be there. And carbonic anhydrase inhibitors will increase the sodium deficiency too. Increased sodium delivery to the distal nephron will lead to more potassium secretion, which leads to risk of hypokalemia. And thiazides, they will also cause potassium loss, but they're going to cause moderate hypokalemia. Now let's talk about whether it's alkalosis or acidosis. But firstly, NaCO3 excretion in carbonic anhydrase inhibitors is going to be self-limited, and potassium secretion and CA inhibitors is also going to be self-limited. But acidosis is not going to be self-limited. So carbonic anhydrase inhibitors are going to cause metabolic acidosis, and potassium sparing diuretics are going to cause metabolic acidosis due to sodium potassium retention due to aldosterone inhibition. Okay. And then loop diuretics are going to cause alkalosis, but this is going to be more severe than the alkalosis which is caused by thiazides, which is also going to cause alkalosis. The PCT is going to carry out isosmotic reabsorption of amino acids, glucose, and nucleosides as we have discussed. It is a major site for sodium chloride and bicarbonate reabsorption. The proximal tubule is responsible for 60 to 70% of the total sodium reabsorption. No currently available drug acts on the NaCl reabsorption in the PCT. The mechanism for bicarbonate reabsorption is shown. Bicarbonate itself is poorly reabsorbed through the lumen, but conversion of bicarbonate to carbon dioxide through carbonic acid will permit rapid reabsorption of the carbon dioxide. Bicarbonate can then be regenerated from carbon dioxide within the tubular cell or the lumen, and then it is transported into the interstitium through the basolateral membrane, across the basolateral membrane, through what? To the sodium bicarbonate co-transporter. And then sodium is separately reabsorbed from the lumen in exchange for hydrogen, which is NH3 sodium hydrogen exchange transporter, and transported into the interstitial space by the sodium potassium ATPase pump. Carbonic anhydrase, the enzyme which is required for bicarbonate reabsorption process on the brush border and in the cytoplasm, is the target of carbonic anhydrase inhibitor drugs. Active secretion and reabsorption of weak acids and bases also occurs in the proximal convoluted tubule. Most weak acid transports occurs in the straight S2 segments distal to the convoluted part. Uric acid transport is especially important and is targeted by some of the drugs used in treating gout. Weak bases are transported in the S1 and S2, but most of the weak acids are going to be transported in the S2, but weak bases are going to transport in both S1 and S2. Sodium glucose co-transporter is responsible for reabsorption of glucose in the proximal tubule, and inhibitors are now available that inhibit this transporter and reduce blood sugar in diabetics.